rattlesnakes in. And then there's elapids, which are things like cobras, coral snakes, which are more neurotoxic snakes. We don't have those around here. We have, this is pit viper, right? So that's a rattlesnake. And you can see that with the blue arrow there, they're called pit vipers because they have these little pits in the side of their heads they sense heat. So that's how like they attack their warm-blooded target. They sense heat and smell and very sensitive. So the 3 snakes that we have in New York State, the poisonous snakes that we have to worry about. So and these are pictures of them from top to bottom. So we have the timber rattlesnake, which was the culprit in this case. Not super common in New York, but not uncommon. And there's several dens of these. Apparently Harriman has a lot of these. Someone found one in their backyard in Sloatsburg recently. So there's, they're around. There's the pygmy rattlesnake, which is very rare. You know, supposedly it exists in New York, but not that many. And then the most common, yeah?
Right, yeah, up by Rochester, that's where they are.
Okay. And then the most common snake we have is the copperhead, right? Most people have probably seen a copperhead at some point in their life. They're fairly frequently around. Not as bad as a rattlesnake, but poisonous as well. So that's what we're dealing with. This is the culprit in this case. So our victim, who was a 24-year-old female, who was visiting, lives in Brooklyn, was visiting from New York, was hiking by herself up in Harriman, feels something on her leg, feels like a sting on her leg, looks down and sees this rattlesnake biting her leg, and then takes a picture of her leg and also takes a picture of the snake while she's sitting there, you know, waiting for people to come up and rescue her. Which was helpful because, you know, you don't always know what kind of things. So I got bit by a snake. And you don't know what it is, but this clearly is a timber rattlesnake. You can see the rattle there in the photo. Just so people are aware, they don't want to bite. They want to run away. There was a rattlesnake only bite if she probably accidentally stepped on it or if they're cornered, but generally they will move away. And that's why they rattle first, is they want you to just leave them alone. So snake venom is a very complicated protein. There's more than 20 different things in there. Basically, what it boils down to is that Viperidae or pit vipers, they have procoagulant enzymes. So they basically affect different parts of your clotting cascade. And the end result of this is it can cause bleeding. It can cause clots to break down, similar like you might see in severe sepsis where they get DIC and their coagulation factors get consumed and then they start having bleeding. So that's a big component of it. And these are the kind of things in there, the hemorrhagens that basically damage the endothelial lining of the blood vessel. So you get what happens because they get leaky blood vessels and you get what's like a distributive shock pattern. So like a warm shock. So she definitely had systemic effects, right? Her blood pressure was 60 when the medic got to her. It was because of this vasodilation and the leaky blood vessels. There's hyaluronidase in there that allows it to spread through the connective tissue, and less commonly these neurotoxins in rattlesnakes, more common in the elapids. So what shouldn't you do, right? So I think most people know this. There's no more like, you know, the snake bite kits. You don't make incisions. You don't suck the venom out. Electric shock, I don't know who's tried that in the past, but you don't want to do any of these things. And most importantly, you don't want to try to capture, handle, or kill the snake, right? We don't need the snake to treat the snake bite victim, but obviously you want to make sure you're safe. So as an aside in this story, apparently that snake stayed under that rock during the whole rescue. And in addition to being lowered down on a hoist when the ESU medic got there and he's trying to get the victim package, people are telling him, you know, watch out behind you, behind the rock. And he's like, why am I watching it? He's like, the snake's still there. So, you know, starts yelling at the troopers, like, all you guys are here and nobody did anything about the snake, to which they responded, well, we were watching for the bear that's in the area. So this guy's like, get me back to New York City. I don't know what the hell's going on here. But so that was the deal there. So what do you want to do? You want to do rapid assessment, resuscitation. Obviously, O2 is required. IV access is key. If you can get 2 large bore IVs in these patients, that's great. You want to assess their ABCs as always. Obviously CPR if needed, but they're mostly, if they have a true envenomating snake bite, they're going to need some sort of hemodynamic support. They're going to need fluids. And then you want to find out, you know, what happened, how has it progressed. Now, again, she was about 2 hours into her snake bite already by the time the medic got there because, you know, it was a long it wasn't easy to get to her. So it was a remote area. So it's kind of like an austere environment. It was a couple hours until she got there. Site of the bite, time of the bite, if you know it, and if you can, snake identification. The patient was great. She had already taken a picture of the snake for everyone, so we know. So a little flow chart. So you have a suspected snake bite, right? Is it a poisonous snake or not? That's the first question. You may not know this. And then something that's important to know is that, are they symptomatic or not? Because just because it's a poisonous snake does not mean it's an envenomating bite. There are dry snake bites. So, and with pit vipers, as much as 50% of them can be dry bites where they got bitten, but no venom was injected. They're not going to have systemic symptoms. So you want to look for, are they symptomatic? And then predominantly, you know, are they having painful swelling in the site? And I say extremity, most commonly these are extremities with a snake bite, right? Because that's usually what you get bitten on, because either you're stupidly trying to pet the snake or do some other stupid human trick that gets you bitten, or you step on the snake. So, and you can get local bruising, blistering, swelling. It can lead to compartment syndrome. And then the vasculotoxic stuff you're looking for, right? Shock, bleeding, DIC. So are they asymptomatic, right? Non-specific symptoms, they may be anxious from getting bitten by the snake, right? So they might have some palpitations, some sweating, they may be tachycardic, cold, they may have paresthesias, right, if they're hyperventilating. In a dry bite, 50%, like I said, of the pit vipers, they may be dry bites, and you may just have local wound care kind of considerations and not actual envenomation to worry about. So, you know, some of the local things you may see, pain and swelling. And again, the level of the swelling of the extremity may not be the same as the level of the pain or loss of sensation. So you want to check all those things. And this is like, it's like, you know, like when a cellulitis, where we'll mark it with a pen, the edge of it. If you're going to be with the patient for a while, that same kind of thing. You want to, you know, note where does the swelling end, where's the pain end, and then ultimately you could lead to some necrosis. So the mainstay of treatment is anti-venom. There are different types that are out. The most commonly used one now is Crofab, which is the one we have. There's another one called Anavip, which is not as specific. The nice thing about Crofab, it works on a whole host of snakes. So if you don't know exactly what type of snake it was, you know, almost all, it's called Crofabs because the family of Viperidae that the rattlesnakes are in are called crotalids. So it's Crofab for all crotalid snakes. And it's kind of made from serum from horse and sheep. They've been immunized with the venom, and then they make it can be monovalent, which works for one snake, or polyvalent. Crofab is polyvalent. So indications, and this patient had them, were any hemodynamic abnormalities. So she was hypotensive. She remained hypotensive. Pressure was about 90 when she arrived at Nyack. Any neurotoxic signs, if it's a neurotoxic snake. Shock, organ failure, and they can get myoglobinuria as well from this, like almost like a rhabdo kind of picture. If the local swelling is progressing, so it's more than half of the bitten extremity, or it's rapidly extending beyond the initial bite site within a couple hours, or you know, large swollen lymph nodes. So those are reasons we give it. There's no absolute contraindication. If they've had a reaction in the past, we just need to be aware of that and make sure that they actually have significant envenomation if we're going to give it. And you have to be ready to treat for anaphylaxis when you're giving this. So, you know, obviously the standard treatment, right? You have epi available, Benadryl, steroids, those kind of things. And you want to observe for response, right? So headache, generalized body aches, pain may disappear relatively quickly. Usually if they have spontaneous bleeding or shock, that resolves usually within the first hour. So just like any other type of shock, fluids first. You know, at this point, the patient was about 3 liters in when her blood pressure actually stabilized to about 120 over 75 or so. Next step would have been, if you were going to give, would be pressors. So, you know, norepi, dopamine. And then if they're bradycardic as well, you can give atropine as needed. So that is a quick little snake bite review, but I thought it was a great case. Ultimately, so the patient was at Nyack for a few hours, stabilized the blood pressure, got the initial loading dose of Crofab going, and then in discussions with vascular surgery about the swelling of her leg, and then with the poison control people in New York City, given that we actually have a regional snake bite center, which most places do not. So that's another unique thing that people should be aware of. Most of the country does not have something known as a designated snake bite center. So, fortunately, Jacoby is, because the Bronx Zoo is right near there, and they have all the anti-venoms for the various snakes the Bronx Zoo has and all that. But most snake bites in the country are just treated at the local hospital, where anti-venom would then be brought to wherever the patient is if needed to treat them. But because we have the abundance of resources we have in the area, the patient was then transferred to Jacoby, where she was there for, I think, another 2 days. Her symptoms all resolved after 18 vials. They gave her a total of 24 vials, and she did quite well. No loss of function of the leg, and recovered nicely. So, but it was a good call. The only feedback I would provide, if you're on these calls, right, it's difficult for us to advise you over the phone when we're not with the patient and have little to no information, right? So again, all we knew, I didn't even know where in her body she was bitten, just that her blood pressure was 60 and that she was bitten by a rattlesnake. So, if you have a better plan or something you want to do, speak up and let us know on the phone, because we can't see what you see, and we can only respond to the information you have available at the time. So, I thought it was a great call. I thought it was interesting. We don't see it that often. I mean, I don't remember the last time we had a true snake bite where we had to give anti-venom around here. But it would be good to talk about. And any questions, comments, happy to hear them.
Can we have that PowerPoint sent to us?
Sure.
Okay, so anything on our rattlesnake bite call? One Leslie Roberts was the medic who hiked up the side of the cliff and was up there with the.
Apparently quite a hike from what I heard.
Yes, was up there with the patient for many hours. She did a fantastic job. So. Okay, anything on that? So the only other thing I had is, that we're in the process of fit testing everyone for 3M half-face respirators. So if for some reason you have not been fit tested yet, just please let me know, and I will, make arrangements. We're at the point now where probably by the end of next week, we're not going to be going out in the field anymore to do it, because we've gotten, the vast majority of the employees done, with the exception of some infrequent per diems. But if somebody got missed, just let me know. We're doing RMC, RPS, the BERT team, CP, anybody who has patient care activity. Angel was able to secure not only the masks, but a decent supply of the filters. So we're actually in very good shape, if, God forbid, things get crazy again. And we're continuing to get the filters in roughly about 10 a day. So we're going to, I guess, once we get to, after we fit test everyone and everybody has 2 sets of an issued set of filters and a backup, we're going to look to have about 1,000 to 1,500 sets of filters on board. We should be in very good shape. So I don't know if anybody's got any comments on that, but that's basically everything I had. Okay, so if there's anybody who didn't, just shoot me a quick email and I'll make sure that gets taken care of. So does anybody have anything else they want to discuss? Dr. Wasserman?
Frank, I just wanted to say just thanks a lot to Josh. He did a really great job with that. He ran around, he got everybody done. He's to be commended.
Thank you. Okay, anything else?
No, just we're happy to have feedback on our new ER. So as you guys come in, if you notice things or something that needs to be changed with the EMS room or whatever, or just let us know.
Okay. Anything else? Okay, please call Arlene. Please call Arlene if you can work. I see her there working diligently in the picture. Anybody have anything?
Where at with?
Go ahead. Who's trying to talk? Jessica?
It was Jessica,
Yeah.
but I couldn't hear her.
Hey, Jessica.
Yeah. So can you hear me now?
Yep.
Okay. Where are we at with the CPAP and nebulizer situation? So I know that we've gone past the triage protocol and we're, going, and we've reverted back to our routine cardiac arrest protocol. But as far as the use of nebulizers and CPAP, have we gone back to doing those things? Are we still trying to avoid them? Where's that at?
I think
I
with a
think,
viral filter, it's okay.
Yeah. Yes. And if you're wearing, you should be wearing, make sure you're wearing the correct PPE if you're going to do an aerosol procedure in the ambulance, right? So that's eye protection, N95, gown, gloves.
Yeah, so
Okay, thank you.
viral filters, Angel was also able to get a supply in. So they're also in very short supply. So we do have a supply of the viral filters. I'll make sure that he reaches out to all lieutenants to make sure that they have adequate stock in the stations. But yeah, bare minimum would be the viral filter. You know, I would wear the half-face respirator and the face shield if you're doing any kind of nebulized. Actually, we had somebody got coughed in the face the other night intubating, and didn't have good eye protection on. So
Just be aware if your guys are taking vacation or traveling this summer that about the restrictions that New York State put in place for various states about coming back to work. So
Yeah,
you're
don't do it.
essential worker, so but you would have to get a COVID test to avoid a 14-day quarantine.
okay. Okay, so if anybody has any suggestions as far as the PPE goes, I mean, some people have given me some good ideas, but it seems like as far as the face shields go, the non-disposable face shields that we bought, you know, the heavy duty ones, seem that's what everybody likes, and then just to clean them after each call. There was some questions about when should you change out the filters on the half-face respirators. So the company 3M offers no guidance because they don't want to get into the healthcare arena as far as, you know, when to change things out and stuff. But their guidance for using the filters in general is that they're good for multiple months. They say that when the user detects more difficulty breathing through the filter, they should be changed. If the filter is torn, exceptionally dirty, okay, or anything, or gets exceptionally wet, that they should be changed. The other thing we put in was that if you are treating a patient that is COVID positive, or you know you have a high suspicion of COVID, then obviously the outside of the filter is going to be contaminated. So at the end of the call, you should dispose it and use your second set of filters, and then just contact headquarters and we'll get you another backup set of filters. So if you actually had a COVID positive patient, you know, when you were in an enclosed room with them, you know, you were the person taking care of them, where, you know, that filter was contaminated, then we would want you to change them out so you're not, you know, having a mask that was contaminated. As far as the mask itself goes, you know, when you were in service, you were told how to clean it. And what's also very important is to periodically clean the exhalation valve so that the mask functions you know, appropriately.
Right, and a lot of people have looked into these masks in the emergency medicine literature too. Some people do things like they'll put a surgical mask over the filters if they don't think it's a COVID patient to try and keep them clean, or they will do things like you know, cover it with like those surgical caps and stuff, you know, like the hair bonnet kind of things. But you definitely can use those filters for multiple months if they're not contaminated.
Right. Yeah. If you're just going, you know, in and out, no COVID, you're just using it, you know, because of PPE concerns, that's fine. But if you had a definite patient or a high suspicion patient or any, you know, any respiratory patients coughing, you know, sneezing or anything like that, by all means, you know, switch them out. We just don't want to get into the situation where we're, you know, blowing through them at a high rate, because with the surges in the other states, stuff is once again getting snapped up, you know, but 3M really ramped up their production, and Uline, the company we're getting them from, has been very, very nice to us in letting us order. They limit everybody to 10 per day, but they let us put a large order in, told us it was going to be months before we got it, and sent it to us the next day. So we kind of lucked out on that. But Angel is monitoring the situation, and you know, he even thought ahead as far as Decadron goes when they talked about, you know, the use of Decadron for COVID. The next morning he called me up and said, you know, I want to buy more Decadron, at least what we use in a year. And I said, absolutely. He bought it. And, you know, 2 days later, it was very hard to get. So he's definitely doing a great job, and he's on top of all of that. Okay, so everybody have a good rest of the day, a good weekend, although the rain does sounds like it's going to be pretty fierce. And I guess I'll talk with Jeff and Adrienne again, and we'll set something up, you know, a couple weeks from now. unless something very interesting happens between now and then. Okay, thank you.
Thank you.
Take care.